Hello, everyone. Today we are here together for this marvelous chirurgical retina section with people from very different countries, from US to Brazil to North Africa and Turkey. And we're going to be very interesting things. We're going to compare different techniques. We're going to learn a lot. And for starting, the kickoff going to be Dr. Garrett from New York. Dr. Garrett, welcome.
Good morning. Thanks for having me. I greatly appreciate the opportunity to speak, and it's nice to be back at one of the international QOIC meetings, even if virtually. I'll share my screen now just to show some slides. So this is presenting a case. I've been using an IOL rescue technique for about 10 years now, and it's a bit of a mashup of other techniques that have been presented and published. It sort of originated because I was doing these cases in Buffalo, New York, and really only had were MA60 lenses. But this was just an interesting one because of the lens type that was involved. So this was a 67-year-old man. He had a dislocated IOL, which is something that we face in a kind of standard way these days. But it was a three-piece multifocal IOL that had been implanted about 20 years ago per the patient. It was a proprietary lens. I really didn't know what kind it was. I'm sure there's someone in the meeting who's familiar with them or has seen them, but it wasn't one that I knew. His pre-op vision was count fingers and pinhole to 20/50. This picture is just of the IOL. I couldn't get a good anterior segment photo because we just don't have the camera at that site, but you can see the multifocal rings, and this is during partial replacement of the lens. But this is just showing what we were working with. I'm going to switch to the video now. So I always start, it's sort of a scleral fixation and a scleral shelf technique. So I always start with peritomies at 6 and 12, but really can be placed in any meridian. So here's the first peritomy. You can see the lens kind of dangling in the anterior vitreous. I always make the peritomies first, just so that it helps guide where I'm going to be putting the trocars. The trocars I like to place a little more at 180 degrees from each other to keep them out of the way of the lens implantation sites, but this can also be modified based on where you want to fixate the lens. I always use 23 gauge in case I have to remove any lens fragments. I've just found that's much easier to use than 25 or 27 gauge. Here I've stained with Kenalog to sort of relieve some of the vitreous from around the lens. I'm usually careful not to remove all the vitreous at this point because I want to support the lens so it doesn't fall back against the macula. That reflection is a little annoying, but just Kenalog that's drifted to the bottom of the eye. And here, just cleaning up the anterior vitreous around the lens. Sometimes I'll fixate the lens on the iris by hooking the haptic to it. This is just using a Kugelin to see if there's any lens capsule. I was trained to remove the lens capsule. I've talked to some colleagues these days who have said they like to leave it. And you know, since showing videos similar to this one, this is the first time showing this one, but since showing videos similar to this one, I've had some of those conversations, and it might be something to talk about or something that people can weigh in on, whether or not to remove the capsule. But I was always taught to remove it to prevent scarring and phimosis that might affect the lens position later on. I think some people now find it might be protective of the iris, and I think that that's a good point and maybe something worth considering. I use a 20 gauge MBR blade to make a sclerotomy. It's basically a straight incision, maybe 5 degrees inferior, or pointing 5 degrees posterior from the plane of the iris. And I extend it in the direction that the haptic's going to go. And I've always done this because externalizing some haptics can be fairly traumatic to them, and they can kink or break. And using a larger sclerotomy prevents that, or at least prevents kinks that can't be re-straightened. So this, then I make a scleral shelf through the corner of the wound and extend it a little bit towards the limbus, because haptics tend towards the limbus when you externalize them. And also if they kink, they're going to bend more towards the limbus, or just tend to do that. In terms of marking, I've tried marking with a toric marker, and I just haven't been as comfortable as just kind of directing my marker across the center of the pupil to make sure I get good centration. And obviously marking is important. I don't use a heavy marker because it just, to me, that is not as accurate as depressing enough to get a good indentation of the sclera. The marker tends to bleed, especially if you've got some fluid around it. So here's just making the other sclerotomy. You'll notice I bent the MVR blade here in left eyes in particular to make the scleral pass. You've often got to bend the MVR blade to prevent it from getting in the way of the nasal bridge or being interfered with by the nasal bridge. So here, just making another scleral shelf. It doesn't matter if you go through, this is a shallow shelf, basically. If you go through a little bit, that doesn't matter, because really all it's doing is protecting the conj from the haptic. And this one, so I externalized it. I couldn't get, it wasn't in view in the video, so I apologize, but I've externalized the inferior haptic here, and you can see a little kink on it. I used a max grip forceps and tried to grab as close to the edge as possible, but it was kind of hanging under the iris, and so I must have grabbed it just a little bit off the tip of the haptic. And in this case, I was a little fortunate, and it straightened back out again. Sometimes if you do that and manipulate it too much, those can break off. And then these are just angle time forceps. So now once the lens is secure, I'll clean up the vitreous more and basically finish the vitrectomy. I always go back once the lens is implanted fully. Here I'm grabbing the superior haptic directly through the sclerotomy. I'm moving the lens out of the way while I'm holding the haptic, and then externalizing through the superior sclerotomy. And if you grab the very edge, you really shouldn't get any kinking at all. And this one didn't have any kinking. An alternative, you can use, when I first started this, I was using 20 gauge Eckert forceps. Those are harder to find these days, which is why I've kind of modified it. So here is tucking in the haptic using angled time forceps. Those are McPherson's, seem to be the best. They slide the haptic right into the shelf, and the superior haptic sliding right into the shelf. The benefit of this is that there's a little bit of room to adjust the haptics or adjust the position of the lens if you need to. So I really don't have many problems with lens tilt. Occasionally, if my sclerotomies are off angle, but lens tilt really is not a big problem because there's a little room to move the haptics and adjust their position to get the lens in the appropriate position. And then one of the features here is I looped the haptic with a 7/0 vicryl, so that first pass of a figure of 8 suture around the sclerotomy is underneath the haptic, and then the second pass is right across the corner of the sclerotomy. And then when this tightens, it both closes the sclerotomy so it's watertight and locks the haptic in position. And that's just going to tighten in a second. And then to close, I've always liked using 6/0 plain gut because it's much less inflammatory and patients are much more comfortable. I'll switch back to the PowerPoint now. So the advantage of this technique is that it's been extremely versatile. I've really had no trouble refixating or saving any 3-piece lens. It uses very common instruments, so no matter where you are or what OR you're in, most places have a 20 gauge MVR blade, different kinds of forceps. It's a fairly straightforward technique, so there's not a large learning curve for it, and less chance of tilt, which allows for some adjustment of the lens if you need to. Some of the disadvantages, it is a little slower than the Yamane technique, especially once you've worked up the learning curve and gotten good at Yamane. It's definitely faster, but I think that the versatility of this makes up for that. And then obviously it's, it requires peritomies, and so there is a little more bleeding, and it's not as slick or cosmetically nice as Yamane either, but I think that it's served me well over the last about 10 years. And these are just 2 other lenses. This one on the right, bottom right, was a single piece PMMA lens that had long enough haptics to externalize them. It was a wonderful surgery, but within a couple of weeks, one of the haptics slipped, and so I had to replace the lens anyway. But it was just sort of showing the versatility and the ability to try to save lenses that may be atypical. So thank you very much.
Dr. Gart, amazing technique. Do you think that's technique is more stable than Yamani, and you can use in any type of lens optical? You can use in different, because you just fixate one multifocal lens, and looks good because was very center and very stable, and we can use this for fixate this multifocal, no?
Yeah, so that's really been the benefit, is that I haven't really needed to worry about what kind of lens is in the eye. So patients coming with a lens that was implanted at some remote time period hasn't really created much of a challenge, which has been really nice. I hadn't thought much of this. I just been using it, and now that I'm working with more fellows, they seem to ask to learn it, and so I thought it was worth showing. But that is the major advantage. Someone asked how far back I'm going with the sclerotomies on the chat, and that's 2.5 millimeters from the limbus.
From the limbus, 2.5. Good. Very nice. For the sake of the time, we have to move on. And now we have from Brazil, Dr. Leandro Zacarias. I'm gonna present different approach for subretinal PVR.
Hello, everyone. Good morning here in Brazil. Good afternoon. How are you guys? And it's a pleasure to be here in this fantastic meeting and to learn with you. And today I'm going to talk about different approaches for subretinal PVR. Subretinal PVR is a condition that sometimes we don't need to deal with. We can leave it there, but sometimes, as I'm going to show it to you, we have to remove it, and there are a few ways to do it, and I'm going to show them by showing a few cases, sharing with you a few cases. The first case is a 22-year-old male with progressive visual acuity loss over 7 months. His visual acuity was 20/70, and as you can see here, he had a chronic retinal detachment caused by some lattice in the supratemporal area, and he developed these strains of PVR that look like a web and went through the macula. As you can see here, it's in the OCT, you have this very sharp angle, and I thought I would have to remove these PVR bands in order to have a good anatomical and visual outcome. So I'm going to show you the video. I started putting a band, a 360 band in this case. You can see how the PVR affects the macula. And that's why I thought in this case I had to remove it. So first of all, I threw a band. I want to make sure you understand, most of the times we don't have to deal with some strains of PVR, but in this case I thought it was relevant. As this is a very young patient, we assume the vitreous is really attached, so I used some triamcinolone to create the PVD. So I'm doing the posterior vitreous detachment right now. And you'll be able to see in a few minutes the lattice where the small holes created the detachment. And after the vitrectomy, then we go for you can see the lattice right now. Then we go for the removal of the bands. This is the approach I use most of the time. I do some endocautery and create a small retinotomy. And by doing at the nasal site, I could pull the bands that went through the macula without having to deal with the macula. I thought that was nice in order not to poke on the macula. As you can see, I removed some strains. There was some traction in the inferior area as well. So I did a second retinotomy, and by applying this tangential traction, I could remove this band. And after those bands were removed, the retina got much more mobile. I used some PFO to stabilize the posterior pole and to trim the peripheral vitreous. Now you can see a very thick subretinal fluid that is leaving from the retinotomy, this Schlerin, showing that this detachment was very chronic. I had a little bit of subretinal PVR in this nasal area, so I decided to do a third retinotomy and remove it. And then I could flatten the retina, do a fluid exchange, laser, all those three small retinotomies that I created, and also laser the peripheral retina where the lattice degeneration created the detachment. I tamponade this with C3F8, and the final visual acuity after a few months was 20/25. So a very good outcome for a complex case. I'm going to move on to the second case. This case is another case where I had significant subretinal bands. It's a 32-year-old, only eye, high myopic female. She had -18, and she had a MAC-on retinal detachment that was treated with a buccal a year before. And after a few months, she redetached the inferior retina with macular involvement due to this circumferential subretinal band that I think you can see here. In this case, I was afraid to do a small retinotomy, and I was afraid of the risk of a chronic retinal detachment due to this very poor RPE that this patient had. So I decided to do a vitrectomy and a large retinectomy and flip the retina over in order to dissect this the circumferential band. And this band was very adherent to the retina, so I had to use the light pipe as a second hand in order to do a blunt dissection and release this band, as you can see here. So I'm using the light pipe in order not to damage the inferior retina. I could remove this band, add on some PFO. It's very important to shave, to trim this retina when you do a retinectomy. I lasered it, through the exchange, and left with silicone oil. This patient remained stable with a vision of 2100, and I could remove the silicone oil after a few months, and she did fine as well. But this is another approach. It's not the most common approach, but in this case, I thought it was a nice approach. And finally, I'm going to show you another case, a very special case. It's a 52-year-old female that had a complaint of a sudden visual acuity loss over the last 2 weeks, especially in her inferior field. And her visual acuity was 20/20 in both eyes. And we could see those bands, those subretinal bands here. In a wider angle picture, you can see that she had superior subretinal bands, and it was caused by a very small hole in the superior periphery of the retina, and she had this chronic retinal detachment coursing with subretinal bands, and probably she realized she had this inferior field when it progressed a little bit. We can see OCT here. We can discuss how OCT looks like for subretinal bands, but always these very hyper-reflective bands below the retina. And I have several views of it. And in this case, we decided we had to treat this patient, but how to treat is a challenge. And we decided to try a pneumatic retinopexy and laser the tear. And this patient did very well without having to remove subretinal bands. And so I have this follow-up. There's a small area where the bands maintained very non-significant retinal detachment there due to distraction, but the patient did very well. So I showed you three different cases. In most of the cases that I have to remove the bands, I do small retinotomies, as you could see in the first case, but we have several ways to deal with subretinal bands, and in most of the times we don't have to remove it. So we need to individualize the approach based on the characteristics of each patient. Thank you for the attention. Obrigado. And that's what I wanted to show it to you.
Leandro, so nice to see your cases, and it's very tough sometimes to remove all the subretinal band. But the question that came on my mind is, as you said, we don't need to remove all the bands, and how to decide to leave or to remove the subretinal band. Sometimes it's not easy decision.
It's not an easy decision. The first case that I showed you, the band was very close to the macula. So I thought it would cause chronic traction even if I solved the detachment. So I thought it would be very nice to remove it in order to have a nice macula for the patient. In the second case, the band was the cause of the redetachment. So it was clear that I had to remove it. Well, those are very special cases. In most of the cases, we have some subretinal bands, and we can flatten the retina even by having a small traction that is left over there. You don't have to deal with that, because in order to remove the bands, you have to do a retinotomy or a retinectomy. It's invasive. So most of the times you can leave the subretinal band there.
Okay, thank you so much. Now I'm
My
gonna move to the giant retina tear. Don't worry, just make it flat. From Dr. Mustafa Shabu. Hi, Dr. Mustafa. Good to talk to you, and my pleasure to have you here.
Thank you very
Go
much.
ahead,
Good afternoon, everybody. It's a pleasure to participate to the nice meeting. I'm Dr. Jabbour from Algeria. Okay. Giant retinal tears are defined as a four-thickness circumferential tear of more than 90 degrees of the peripheral retina. In the majority of cases, the posterior there is a posterior vitreous detachment. They can be spontaneous or occur as a result of member and of conditions. Surgical management may be challenging due to its high risk of intra and postoperative complications. They count for approximately 1.5% of regmettanous retinal detachment, and the average age of incidence is 42 years. There is higher incidence in males than females. Although general retinal detachment can occur spontaneously, and they're often associated with a number of conditions. About 12.8% of patients develop bilateral general retinal detachment. This pathology occurs from liquefaction of the central vitreous associated with peripheral vitreous condensation. Concomitant actions in the region of the vitreous base will result in circumferential tearing of the retina. In these conditions, the vitreous remains attached to the anterior flap of the retina, while the whole posterior retina moves freely and can fold upon itself. This increases the risk of PVR because RPI gains success to the vitreous. Let's you show my video. Here we are using 23 gauge sclerotomy, and you can use the 25. We prefer using a valved cannula system to decrease the incarceration of the vitreous and the retina in complicated cases. So we've done a third vitrectomy, and it's important to do the vitrectomy, the anterior vitrectomy, as fast as possible, because in the majority of cases, spontaneous PVD is already present. The vitreous base is doubled to the maximize extent possible using high cut rate and low vacuum. Here we can see that the posterior flap of the tear is inverted and the edge is unrolled. The anterior flap of the tear should be completely removed with adherent vitreous to avoid the circumferential anterior PVR. When the flap is inverted, we can unfold the retina using PFCL. We gradually inject it over the optic disc as an enlarging sample bubble to avoid small fish eggs to cross under the retina. Here, as you can see, the edge of the posterior flap is unrolled and contracted. So we decide to proceed with endodiathermy to ensure the hemostasis before trimming the posterior edge of the giant retinal tear. Then we are trimming the posterior flap with the vitreotomy. And we performed the laser along the posterior edge in 2 or 3 rows of burns. In our practice, we also prefer to do 160 degrees of laser. Cryopexy is done along the retinal tear horns. And finally, we prefer doing direct PFCL silicone oil exchange to avoid the slippage for the posterior flap. So the comparison using the gas versus silicone oil, while some studies demonstrate that gas has a better visual outcome with fewer complications like uveitis, direct PFCL oil exchange is useful in cases of giant retinal tear because of minimizes the risk of retinal slippage. Using the buccal or not, some authors find that scleral buccal, in addition with vitrectomy, may decrease the peripheral traction, especially in phakic patients, while others consider that when the general retinitis is up 180 degrees, it acts like a retinectomy with decreased traction of the vitreous. And concerning the ILM peeling seems to prevent postoperative epiretinal membrane develop. In conclusion, the management of general retinal tears poses significant challenges due to the many complications and technical difficulties involved. The most important peels in the management of giant tear retinal detachment include trimming the edge of the tear well, injected PFCL as a single bubble, drying the edge of the brick thoroughly to prevent slippage. Thank you for it, your attention.
Thank you so much. It was a very good talk, and it's a challenge to operate patient with giant tear who have so many difficulties during the surgery. You just explained that we use direct PFO and silicone oil exchange to prevent slippage. That's something that's very frequently. And we know that's one of the problem of the giant tears is the anterior flap that's we have in the left, and this anterior flap can cause many problems. How to deal with this anterior retina that's left behind?
We do we took off the retinal flap, the anterior retinal flap, faster and possible during the vitrectomy to avoid the incarceration in the sclerotomy.
Yeah.
So we can use indentation with my collaborator, for example.
Yes, as you said, that's very important to trim it, all the anterior flap of the retina, because we can have incarceration, and also we can have PVR that connects this flap with the ciliary body, and this can contract, and we have chronic hypotony, and this is very important. But your technique is superb. I like very much, and I think many people learn a lot with your talk, that you explain everything from the pathogenesis to the treatment. Thank you so much.
Thank you.
But we need to move ahead to keep on time. And now we're gonna have the next talk from Dr. Ahmed Beda and giant retinal break, unusual presentation. Please, Professor.
Yes, good afternoon, everybody. Thank you very much, Dr. Roca and the organizing committee for giving me the chance to participate in this meeting. Now, this is can you see my slides now? Can you see my presentation now, Dr. Roca?
No, not yet.
No, not yet. It's not shared yet.
I'm trying now to let you see it.
Okay, thank you.
So I still cannot see it. So can you give me the chance to return back to the Zoom meeting in order to share my screen?
Somebody for technical support, please help us.
Hi. So, are you on your Zoom screen? Can you see a green share screen button on the bottom panel in the center of the screen? green color button that says share screen. Yeah,
So right now?
now we can see. Thank you so much.
Okay. Okay. So this is about another giant retinal break. Actually, this is a case of giant retinal break retinal detachment with unusual presentation for at least myself. So this is a patient who presented with this retinal detachment, which is present in the inferior basal part of the retina. You can notice the presence of this fold. Can you see it here? And the retina temporal to this fold is attached. When I went to the periphery of the retina, can you see the full picture of my my detached retina? You can see a giant retinal break in the periphery of the retina. Can you see it, Dr. Rocca? Is it clear, or the bar prevents?
Yes, clear, clear. You can see.
Clear. Yes. So if you notice here, this lateral edge of the giant retinal break is somewhat centrally displaced, and this part is attached. This fold is formed here. So the question is actually, how did this fold form? No other retinal breaks are present. It's only this giant retinal break and detached retina. So the explanation for me was that this part of the retina was probably totally detached, and then it's spontaneously reattached in a wrong place. So this part, which was temporally located, is displaced nasally and formed this fold here. So the question now is, can perfluorocarbon liquid injection solve this problem? Can perfluorocarbon liquid flatten this fold of the retina? The answer to me was that if I inject perfluorocarbon liquid in this situation, this will not displace the retina temporally, because this part of the retina is attached in place. So if you inject perfluorocarbon liquid, this will make a compression fold of the retina, which actually will be very difficult to treat later on. So how can we solve this problem? I thought of two things. The first is to use a 41 gauge needle to inject fluid under the retina in order to elevate this part of the retina and then displace it with perfluorocarbon liquid. However, I felt that injecting injection of subretinal BSS here with a 41 gauge needle might lead to escape of the fluid in this part of the retina, which is detached already, and will not, this fixed fold will not allow the fluid to detach the part of the retina which is attached in this part. So I thought of another thing to do. Actually, this was my first time to see such a fold with giant retinal breaks. So this is the video showing the part of the fold here, and the part which is attached temporal to it. I decided actually to mechanically detach the retina. So I used the forceps to catch the edge of the giant retinal tear, starting to detach it from the periphery to the center. It actually worked in the beginning. It was easy to detach this part. However, exerting traction manually after some time started to create tears at the periphery of the giant retinal break edge. So I shifted to use the back surface of the vitreous cutter itself to mechanically separate this retina from the retinal pigment epithelium you can see here. Unfortunately, the use of the back surface of the vitreous cutter led to some traumatic damage of the RP. You can see it here. I continued actually to detach mechanically this part of the retina until reaching the temporal edge of the optic nerve head. You can see here some trauma to the retinal pigment occurs heterogeneically. However, you can not see it. This is the optic nerve head. I have just reached it. At this point, I felt sure that this fixed fold now is unfolded, and I think it's safe now to go for injection of perfluorocarbon liquid. And you can notice that injecting perfluorocarbon liquid actually led to flattening of this fold, and the retina got flattened, and I continued as usual with laser treatment and then air perfluorocarbonate with exchange of silicone oil template. So this is the appearance probably 1 week after surgery. The central retina is attached, and this is the periphery. If you compare the image before surgery and this is after surgery, the fold has disappeared. And if we compare the composite fundus photograph, the retina was totally flattened and attached. And this is the appearance 1 week later, where everything was finally attached. So thank you very much for allowing me to share this experience of this patient with you. Thank you very much.
Thank you, Professor. Very unusual case for sure. And you make this with a lot of skills and has a very good result. And do you think that if you just attack the giant tear and leave with oil and position, the fold will not open with time, just with the pressure of the gas or oil?
This fold is present between the macula and optic nerve. And if this fold is unfolded, this will lead to a terrible fold, which will definitely affect the final visual outcome of the patient. This will produce definitely metamorphopsia, and the patient will definitely be unhappy. I felt I should have unfolded this fold before proceeding with completion of the surgery.
Yes, I agree. Very nice. Let's move because we are almost the end and we have more beautiful talks to see. And now our friend from Turkey, Dr. Nur, is going to present the chronic retinal retinal detachment in a child, read technique to choose. Okay. Hi, Dr. Nur, you are very welcome here. Thank you for joining us, and it's all yours.
Thank you. It's my pleasure and honor to be here with you with such a nice talks. Thank you for the kind invitation. I'm from Istanbul. I'd like to share my screen now. I think you see my screen now. Just a minute. So there has been many talks related with the subject also, but in a chronic rheumatogenic child, this is our case now. It's a 7-year-old boy referred from abroad, and it's a left eye. It is like -13 dioptry myopic eye. And the mother talks that the chronic retinal detachment maybe since 3 years, but since 6 months, the vision is affected. So the vision was worse. We know this from the history. And when we examined, as you can see here, there's demarcation lines. Only the upper nasal side is attached, but the rest is detached. Macula is off. It's some thin subretinal membranes. Maybe this is not the periphery now, but also under the fovea, there's some kind of membrane formation. And the big tear, big horseshoe tear infra temporarily. So which technique to choose? For young colleagues, we have some, we already know that we have 3 options, and sometimes we combine the techniques. In Turkey, we have a saying that every man or every brave man has his own way of eating yogurt. So this is to show that, of course, we should pick the technique that minimum morbidity and complications, and with the highest first surgery success rate and functional recovery. So, and also regarding the technique to choose from in a detached eye, of course, we consider many factors like the eye of the patient, and also the experience of the surgeon. Sectoral buckling, as we all know, that has a single operation success rate and also visual acuity higher in phakic eyes already in the studies, and especially young myopic phakic eyes, inferior breaks, dialysis, pediatric cases, especially, which we all see some cases already, chronic inferior detachments, and even some subretinal bands, and even some PVR, we can go for the buckling surgery. It's an extraocular surgery, preserving the lens, of course, but needs experience, and the learning curve is a bit higher. So we can pick the conventional method, but we need the good use of indirect ophthalmoscopy. And there's always, there has been chandelier-assisted buckling has been very popular since its publication because of the better visualization and because it's educative. And we may find small tears in small pupils if there's a media opacity, and even we may increase the indication in antidactyl or even some posterior tears. So the case, when I go back, so I picked scleral buckling in this case. It is a surgery now. It's a bit fastly edited, but I will just stop in between sometimes, because first we should have a plan in every buckling surgery, considering especially young colleagues if they are watching us. We put the scleral band first and suture, because when we put the chandelier, we may just touch the lens when we just turn around the eye. And then this is the band sutured, where we will not use for a drainage or something. And this is the chandelier. This is the trocar. We may use 20. Smallest is the better, actually, 27, 3, or 5. And the trocar, I prefer valve, because we sometimes and get in the eye. And so this is the retinal exam. As we can see, it's like the vitrectomy, wide angle visualization. We can see there's a large tear infratemporally. It needs a radial buckle, of course, because to prevent the fish mouth phenomenon. And then the retina is detached, some membrane. So the radial buckle is placed, is marked. I sometimes use diathermy just in the middle, because the marking point just cannot be so sharp and in the wet area. I put the radial sponge, and I mostly drain subretinal fluid, except very shallow detachments. I prefer the conventional method, which I'm very happy for. And I don't push for the drainage area, but I just lift the area to the from back to front, so it makes, and you can in this way make the posterior fluid come to the periphery and drain readily. So exceptionally in this eye, I preferred, exceptionally in this eye, I prefer to do with the curved laser probe with light illuminated. So as the surgeon uses the laser, we have to move very slowly in the vitreous, of course, and it's good focus. You can do very nicely your laser. You can see very well, like in the vitrectomy, but of course in the video it's not shown very nicely. So you can see those macula is already attached. It is membranes. There's a cyst in the nasal area, but the band is located covering all these areas. So I take out the trocar. We should always clean the vitreous, and scleral entry must be sutured, because there may be some vitreous wick and risk for endophthalmitis and detachment, peripheral tear, of course. So the band tightness is checked, and this is the end of the surgery. So of course, we sometimes do the cryotherapy if we have at hand, or indirect laser ophthalmoscopy. So this is the retina. It is attached to first postoperative day. As you can see, the demarcation lines, some thin membranes down, especially the macula even, and the radial sponge is placed at the right place, and the macula is attached with a visual post-op recovery of 20/200. So why I picked this case, because I have to give the message, my take-home message for especially young colleagues, especially in young, high myopic eyes, pediatric eyes with subretinal bands. We should always go for buckling first, because of the many technical problems. The posterior hyaloid is very tightly attached, mostly in these eyes, and the vitreous is formed. It makes a good tamponade effect, and we can preserve the lens. But we should teach and learn the technique, of course. And chandelier-assisted vitrectomy buckling gives us the opportunity to increasing the usage of this nice technique. So thank you for your kind attention. And I would kindly like to invite you to the 20th European Vitreoretinal Society which can be registered also online at the end of August in Cappadocia, Turkey. Looking forward to meeting you there. Thank you.
Noor,
Hi.
it's amazing as always. And thank you so much for this wonderful talk. And I think your message is very important for the young surgeon. Buccal is still a very good option, in special in young children, because the vitreous is very attached. Go for vitrectomy is not easy, and sometimes have so much complications, and sometimes kill the eye. And then you have shown something that's very unique. You just place a circumferential band, and underneath you put a sponge, radial sponge, to make sure that we have a very good indentation in the right place, and make sure that you protect all the vitreous base. And do you think, my experience with sponge not too good, but your experience, you think that sponge in that position gonna not be strewed and have complications?
Actually, I have many experience with the buckling and radial sponges, and also sometimes circumferential sponges with grooves. For example, if you make your sclerotomies deep enough and you suture, for example, I don't make the knot in the beginning. It is maybe a trick, of course, maybe we all do. After drainage, the eye become a bit hypotenuse, and then you make your knots very nicely. And whenever we making the knots, always my assistant just holds the suture and indents inwards. Not I don't do it myself. I just ask my assistant to indent the knot. So I suture one and then one and make a tight suture, of course. And the second one, the conjunctiva, if you close the tenon and the conjunctiva, I also make it important to close. Whenever I open, I close, like I open the door, open the eye before I touch the eye. So, and so what I do, radial sponge, I just trim the ends and make it not like a strict hole, but I just trim the ends, for example, make it like an oval or a bit, whenever the sponge is close to the conjunctiva, the limbus area, I trim it. It's half, for example, half thickness. And so it is the buccal, radial, and that comes to the limbus area, it is less in thickness. I think it is the tenon just closes on top, and it becomes, the surface is a bit not so smooth. So the tenon is attached very nicely. So I didn't have any case with, how to say, it is always in its place, let's say.
It's good. And you has shown as well the chandelier technique. That's pretty nice. And what tips you can tell about this technique? And the specific question is, do you have any specific chandelier brand that's better than the other for use in buccal chandelier?
Mm-hmm. Actually, we can, the less is better, because we have one company like with Twin Light, for example, because it needs two entries. We can use only one of them if you like. And smaller gauge is more, actually, the smaller is the entry, the less vitreous can come out. So, but trocar, I think, is nice to have, because in other cases, we have to be, it can touch the, for example, the Twin Light, we use the Twin Light without the trocar, it can touch the lens. So when you have the trocar, it can be 27 even. I don't recommend especially one brand. The light should be nice, and it should be one that you are used to using in the vitrectomy setting also. And the valve support, because in some maneuvers, I just take it out and I take it in, take it out. So because, for example, the drainage, you just turn the eye. So you have to, again, take the light off. I think these are, and the area to make the chandelier should be at least 9 degrees, 120 degrees apart from the primary break. It can be nasal, inferior nasal is usually a nice area for the superior breaks. But in this case, the break was down inferiorly, so temporal area has a lot of space to move. I think temporal area, superior temporal or inferior nasal are good places. And we must always suture and check the vitreous whenever, if it is small or not for the vitreous.
That's great. Very good tips indeed. And then I think buccal is still a very good option. People has to learn this. And maybe we have here Dr. Mohamed, and that's the president of MION. Maybe he can organize a buccal course in MION this year. That's pretty nice. And thanks so much. I think EVRS in Turkey, Cappadocia, gonna be a great meeting, and I hope everyone can go there and have a good time there. And I think we're gonna have some last words of the President Mohamed Anhi. That is the guy that's behind the stage and organize all this. Thank you so much to be here with us.
Thank you.
Thank you very much, George, for moderating these sessions, and thanks for all our great speakers, friends. Thank you, Noor. Thank you, Dr. Ahmed, Leonardo, and Dr. Gareth, and Dr. Jabour from Algeria. So all of you, you have done a great. I don't have anything to say. That I would like only to thank you for accepting our invitation and be with us and give us a chance for everyone they are listening to learn from your experience. And we hope to see you also in MIOM conference in October 19 to 21 in Dubai in physical. Thank you very much and have a nice day.
Thank you very much, Mohammed.
Thank you.
Thanks so much, everyone. Was a great section. I think we learned a lot. I think all the audience is very happy with all the techniques and new ideas that you just have shown us. And thank you so much for your time and appreciate that. Thank you all. Bye.